Okay. Good afternoon, all of you. Good afternoon, especially Dr. Devendra Sareen, Dr. Atul Shankar, Mohit, Neha, Rinku, and Dr. Vijeta, and of course the young budding pediatricians, Dr. Anjali. I'm really happy to note that Mohit and Dr. Atul Shankar, they are teamed up to start this program, which I felt was a long-awaited need in our zone because most of the time I used to feel very upset to see that most of these kind of a PG or UG clinics were being conducted in the southern region or eastern region. But I am very happy to note that this has now started in our because we have immense number of very talented pediatricians and academicians who will be able to contribute to the academic excellence of our children, and the residents would definitely benefit with them. And with the challenging cases we see in many of the medical colleges, and sometimes I usually you felt that many of them used to be lost to sort of follow up because not everyone could see it. And these are sometimes you see that the once in a lifetime case, suppose, comes in, or twice or thrice, one unusual case, and you really didn't find them to be shared. It has to be shared with among everyone so that everyone gets a view of it. And during my time, I usually used to feel that yes, we lost many of the cases to this kind of a follow-up where we I could not show it to the whole of the pediatric community. Case reports are there on the journals, but this is a more interactive and much more useful, where you can actually start thinking and go along with the person who has handled the case and how they have proceeded with the case, how they would be thinking. And I must, especially to the residents, the message is that when the case discussion starts off and the initial case presentation is made, you start thinking on your own how you would work up and how what you look for in this child. Don't just sort of blindly look at the whole thing or just look at the screen and follow the trend. Start thinking the moment the case is presented to how you would proceed with it, and just see whether you are going on the same line of thought as the person who is presenting it, and you are able to conclude it the same way as they are going to conclude it. That will be a mental exercise which you should all do. And also for the young pediatricians, they should do that. I think with that, I'll let's say, since it's the inaugural session for this PG clinic, I wish all the best for the future and congratulate again the whole team of Jaipur IAP led by Dr. Atul, that they should proceed to continue this kind of activity for further uh, furthering the academic knowledge among the residents and young pediatricians. Wish you all the best. Thank you.
Thank you, sir, for the words of blessings. And I think sir has really passed on the message very good that this is basically the residents are going to be benefited from this, and not only the residents, even the clinicians. Day to day, we have been seeing such cases which are missed, which are lost, which are very important to brought to the surface. And that is one of the purpose behind this case presentation. Now I'll hand it those over to the moderator of the day, Dr. Neha ma'am, and now she will lead throughout the case. Whatever the queries, I request everybody to please put it in the chat box, which can be discussed time to time with the experts and the chairperson, sir, Dr. Sitaraman, sir. So up to Dr. Neha Agrawal, ma'am. Ma'am, up to you.
Thank you, Dr. Mohit. Thank you. Thank you, Dr. Mohit. Am I audible?
Yes, yes, you're audible.
Yes. So very warm welcome to everybody, although it's already too warm outside, but we are blessed with some good rains. So with that background, let us proceed with the case which we are presenting today. And it's a disclaimer that this case would not progress from the present day, but from when the child has had come to us. And another thing is, I just want to make it a point here is that this case is not a very extraordinary case. But of course, it takes us to the dilemmas and the fallacies which we face in our everyday OPD practice, and which leads us to miss some of the very important pointers which are present in front of us, which we often miss or we often unknowingly neglect, and which may have a bearing on the patient's further prognosis. So I would hand over the mic to my dear resident, Dr. Anjali Sharma, who has taken great pains in making the presentation. And it's very appreciable that she has made it a very good effort to compile the slides in a very nice manner. And of course, I would thank my co-faculty, Dr. Rinku Seni and Dr. Vijeta Tomar, who have put in a lot of effort to make this case a very good one. So over to you, Anjali. You can start with your case.
Good afternoon, sir. Sir, I have special thanks for Dr. Sitaraman sir, Dr. Atul Sankar sir, Dr. Devin Sarin sir, Dr. Mohit Vora sir, and ma'am, Neha ma'am, Rinku Sani ma'am, and Vijeta ma'am. They give me platform to perform. I will start my presentation. Ma'am, my screen is posed.
Yeah, your screen is visible.
Yeah, you can share your slides. You can just scroll through the
This is
slideshow.
showing your screen sharing is posed.
Okay, so Vikasji, please
Just a second, let me
allow
check.
her to share her screen.
Just a second, ma'am.
Meanwhile, by the time they come with the screen sharing, when the topic of this case was, came, it was a child, it was a clash between the rheumatology and the nephrology. So there was a discussion that whether this is a clash or a case. So we were just wondering, it's miswritten that it is a case of neurology and rheumatology or a clash between neurology and rheumatology. But then the Dr. Neha cleared that, put that anything, the case is going to be a clash. So even whether you write case or clash. So I think that's what is the beauty of this case, a child with joint pains and proteinuria.
So
So
basically, what happens is not everything is a, yeah. So
Ma'am, we
not
have checked.
everything goes on
hello?
a single track, actually. That's what we have to understand. That, yeah, Anjali, can you share your slides now?
No, ma'am.
क्या प्रॉब्लम आ रही है विकास जी?
तुम्हारे स्क्रीन में मूव कर रहा है क्या अंजलि?
No, sir. Move नहीं कर रहा.
नहीं, तुम्हारे स्क्रीन में, कंप्यूटर स्क्रीन पे.
No, sir. Sir, there is the sign. Your screen sharing is post on above the slide, sir.
आप एक बार बंद करके स्टार्ट करो अंजलि.
हाँ,
तो
वहां
host
से बंद करके चालू करो. हाँ.
हाँ.
बंद करके. Okay, sir.
आप एक बार प्रेजेंटेशन पे भी क्लिक कर सकते हैं मैडम, एक बार क्लिक करके फिर मूव करना हो जाएगा.
Yes, sir. Okay, sir.
स्लाइड चेंज कीजिए. हाँ, हो
Yeah,
जाएगा.
And it is on now. Do it.
good. चालू.
Yes, sir. Sir, I'm Dr. Anjali Sharma, PG resident third year from SMS Hospital. I'm presenting case of Chanda. She is a 12-year-old female Hindu. She is resident of Bharatpur, Rajasthan. And we are presenting this case when she first presented in the pediatric nephrology department, which was on 23rd of the May in 2024. Sir, she was presented with a presenting complaint of generalized swelling since 5 to 6 days, vomiting since 2 to 3 days, and joint pain since 2 to 3 days. Patient was apparently normal 6 days before admission. Then she was presented with complaint of generalized swelling, which started from the face, then progressively to the abdominal distension and insidious in onset. It was followed by bilateral pedal edema. Edema was pitting in nature, sir. Sir, there is the complaint of vomiting. Since 2 to 3 days, vomiting was non-bilious, non-projectile, 2 to 3 times per day, contains food and digested food particles. Vomiting was not associated with any blood. There is the complaint of pain in bilateral wrist joint. So the joint pain was not symmetrical. It was always more in right side than the left side. There is the bilateral ankle pain and bilateral knee joint pain. Since 2 to 3 days, it is associated with the swelling and the restriction of the movement, sir. Sir, negative history. There is the no history of the fever, no history of pain abdomen, no history of loose stool or constipation, no history of jaundice, no history of hematemesis, melena or rectal bleeding, no history of muscle weakness, no history of skin rash, no history of oral ulcer alopecia, no history of weight loss, no history of breathing difficulty, and no history of oral dryness, no history of dryness of eyes, difficulty in vision, no history of Raynaud phenomenon, no history of skin thickening, no history of puffing of fingers, no history of photosensitivity, and no history of hematuria and oliguria. So this case was firstly supposed to be the GI system involvement due to the massive ascites. So there is the all GI complaints were negative in this history. But then next the diagnosis was, sir, going to the generalized swelling in the kidney part, sir, and associated with the joint pain. So there is also association with the some rheumatological complaints, but there is no association complaint of the rheumatological part also. Sir, past history. Patient has complained of the joint pain, swelling, and limitation of movement since 3 years of the age. She was taking oral, OPD-based medication on and off since 3 years of the age. But patient first presented in the SMS rheumatology department in August 2023. So there she was evaluated for this and diagnosed as juvenile idiopathic arthritis polyarticular type, rheumatoid factor negative. Sir, this time patient took treatment naproxen in the first month, then tablet hydroxychloroquine, methotrexate, iron folic acid, and prednisolone. Since then, sir, she was taking for the 4 months total duration of the treatment. Patient said she has relief in the symptoms for the 4 months, but after taking treatment, she has again the complaint of the same. So patient was lost to follow up since December 2023. Other than this, this patient has no history of previous hospitalization and no history of previous generalized edema. Sir, during the August 2023, when she was first appeared in the adult rheumatology department, there are some investigation in which serum albumin was low, 2.1 gram per deciliter. CRP was positive, ESR was 120, urinary protein was 3 plus, sir. Other than this, sir, vitamin D level was low, 12.85 nanogram per ml, sir. Sir, after this, sir, investigation, sir, she has taken एक second, sir. So after this investigation, she has taken 4 months of medication and she was not on the follow-up. So the routine investigation was not repeated after this. So course of the illness was in August 2023, patient appeared in the rheumatology and with the complaint of pain, swelling, restricted range of motion, and during the course of treatment, pain, swelling, and so decreases, and the range of motion is the increased. But during this course of treatment, patient also took prednisolone, sir. Then patient was lost to follow up, and patient was presented in the pediatric nephrology in the May 2024, sir. Family history. There is a history of arthralgia in grandmother since 20 years. She is taking oral medication for pain relief on and off, sir. Sir, there is history of grandfather. He was expired in the old age due to the renal failure. Sir, there is the history of the alcohol, and there is also history of ascites. So maybe hepatorenal syndrome, sir. Sir, there is no history of generalized edema or nephrotic syndrome in family. No history of tuberculosis in the family. Immunization history. Patient is immunized up to 5 years of the age, and there is the BCG scar marks in the left arm, sir. Allergy history. There is no known reaction from any drug, no history of allergy from any medication, food, insect sting, contact allergy, or transfusion reaction. Sir, summary. My summary is a 12-year-old female who was previously diagnosed as juvenile idiopathic arthritis polyarticular type with joint deformity, now presented with complaints of generalized swelling, vomiting, joint swelling and pain, and was suspected as nephrotic syndrome and was further investigated for the same.
Yeah,
Next,
just a moment, Dr.
yes.
Anjali. Can you tell me what happened between when she was lost to follow? What was the clinical course and what was the symptomatology during that period?
Yes, sir. Sir, according to the patient, sir, she stopped medication in December 2023, sir. After medication stopped, she has, sir, some period of relief between the period. But after 6 months, after 5 months, sir, in 2024 May, sir, she presented with the same illness of the joint pain, swelling, and the associated symptoms of the generalized swelling, sir.
Okay, after 6 months.
Yes, sir. For five
Of,
months, sir.
and she was symptom free during the in between.
No, sir, not completely symptom free. She was partially symptom free, sir, from the joint pain.
Okay, go ahead.
Yes. Sir, then general physical examination. Sir, during the admission, patient was conscious, sick looking in appearance, lying down position, not comfortable in the sitting position. There was puffiness on the face is present and visible edema in the abdomen and the bilateral pedal edema was present, sir. There is the no signs of icterus, cyanosis, pallor, lymphadenopathy, rash, mucosal ulcer, alopecia or redness of the eyes, sir. Sir, vital examination, patient pulse rate was 84 per minute. It was recorded in the right radial artery regular. Sir, good volume, no radial or radiofemoral delay. Respiratory rate was 22 per minute. Blood pressure was 108 by 70, measured in left arm. Sir. Temperature 98°F, and saturation was 99% in right index finger. Sir. Sir, in urological examination, sir, we have done the urinary protein of this patient, which was 3 plus. Abdominal girth was 66 centimeter and weight was 37.5 kg on the admission. And the anthropometry was, sir, patient weight was 37.5 kilogram, which was 25th to 50th percentile. Height was 147.3 centimeter. It was 15 to 50th percentile. BMI 17.36. So 15 to 75th percentile and SMR staging was Tanner stage 4. Sir, this is the WHO chart for the height for age, in which patient was, sir, in between 15 to 50th percentile. Sir, now systemic examination, sir. Sir, firstly, we have done the gastrointestinal system examination. Abdominal was distended uniformly. Fullness of flank is present. Umbilicus is in normal position and transverse slit-like in shape. All quadrant of abdomen moves with respiration. Vein on abdominal wall is not visible. There is no scar sinus hernia on the abdominal wall, sir. Sir, on palpation, on superficial palpation, the local temperature was normal. Abdomen was tense. There is no tenderness, guarding or rigidity. On the deep palpation, sir, it was done by the dipping method. There is the massive ascites. Liver was palpable 2 centimeter below the right costal margin and spleen was not palpated. There was fluid thrill was present, sir. On percussion, dull note on percussion of the abdomen and on auscultation, bowel sounds were present. Sir, genitourinary system examination. Inspection was, sir, same. There is the Tanner staging of genitalia stage 4 and no visible, sir, hernia on the cuff impulse. On palpation, fluid thrill was present, but bimanual kidney palpation cannot be possible due to the ascites. Fullness of renal angle urinary is present and urinary bladder is not palpable. On percussion, there is a dull note is present. On auscultation, there is a no venous hum or renal artery bruit is present. Sir, next examination is the musculoskeletal examination. The musculoskeletal articular examination did reveal swelling, tenderness, and decreased range of motion in the joints. Sir. The back examination was unremarkable. Patient has normal muscle strength in all proximal muscle groups. Muscle tenderness was not present and gait was normal. So, sir, there were some joints which were deformed due to the, sir, long standing arthritis. Sir, there is a table. Sir, first was the ankle joint which was affected. On inspection, there is the bilateral swelling, erythema, and the hallux varus. On palpation, there is the tenderness and swelling, and there is the restriction of the dorsiflexion. On wrist joint, there is no swelling but tenderness is present and the restriction of movement is also present. On elbow joint, bilateral cubitus valgus deformity, which is more in the right side than the left side, tenderness and the flexion contracture and the restriction of the pronation of arm is present. In knee joint, there is no swelling, but tenderness is present. And temporomandibular joint, there the tenderness is present along with the sir, movement restriction. There is the small mouth opening in the child. So this is the picture of the patient. She has the cubitus valgus. This is present in the both arm, but more in the right arm, sir. And this is the hallux varus, sir. So next is the respiratory system examination. On inspection, chest wall symmetrical, breathing pattern is normal. On palpation, there is no abnormality or any crepitus. In the percussion, resonant node in the bilateral lung areas, and on auscultation, bilateral air entry equal. No other abnormal sound was present, sir. In cardiovascular examination, inspection was normal, chest was symmetrical, no cyanosis, no scharma. On palpation, temperature was normal, heart rate 92 per minute. Apical impulse felt in the left intercostal space, sir. Left fourth intercostal space. On auscultation, sir, heart sound heard in all 5 areas. S1, S2 normal, no murmur heard. So nervous system examination, higher mental functions are normal, patient is conscious oriented, speech normal, memory intact, sir. So cranial nerve examination, all 12 cranial nerve functions are intact. Motor system is a tone is normal, power is 5 by 5 in all 4 limbs, DTR 2 plus in knee and ankle, and plantar is flexor. Stance and gait is normal. On sensory examination, all superficial sensation, touch, superficial pain, temperature, and deep sensation, deep pain, pressure, position, vibration in the joint sense, all are intact. No cerebellar sign was present. Normal spine and cranium, no sign of meningeal irritability. Sir, after examination, sir, there is an investigation of this patient. Sir, investigation. Firstly, sir, we have done CBC. So, sir, hemoglobin, WBC, platelet counts all are normal, but there is the decrease in serum total protein and the albumin. Total protein was 4.5 gram per deciliter and albumin was 1.16 gram per deciliter. Liver function test were normal except LDH, which was slightly raised, sir. 543 international unit per liter was LDH during this time. Serum cholesterol was 440.29 milligram per deciliter, sir. So urinary protein or urinary creatinine ratio was 10, which was suggestive of the nephrotic syndrome, sir. Next is the sir rheumatological examination. There was rheumatoid factor was negative. Anti-CCP value was less than 0.40. ESR was 105. CRP was negative. ANA by IFA also negative, sir. Anti-DS-DNA negative. C3 is normal. Serum ferritin is, sir, 165.9, which was normal on the range. All viral markers are negative. DCT was negative, and sir, CPK-NAC was on the normal, sir, 56. Sir, in this investigation, sir, which we have supposed that this function with the joint pain and the proteinuria, maybe, sir, she can be also SLE. She is an adolescent girl, but sir, all the investigations marker for the SLE was negative, sir, here. And sir, the second possibility was also MAS, macrophage activation syndrome. But sir, this was not investigations was not in the favor of the sir MAS, sir. As sir, next investigation was ANA by immunoblots, sir. Sir, all 18 antigens were negative. Sir, X-ray bilaterally, it is showing decreased bone mineral density with mild decrease in joint space and thinning of the cortex, sir. So then X-ray chest shows normal lung field, no hilar lymphadenopathy. USG abdomen, there is no hepatosplenomegaly. Kidney size were 101 into 36 mm in right and left is the 111 into 43 mm normal. Gross ascites was present, sir. Sir, renal Doppler, there was a segmental artery intermediate resistance during initial, sir, USG, but later, sir, it was the normal, sir. There's the sir, no resistance was seen in the later, sir, USG. USG chest, bilateral mild pleural effusion was seen. So sputum CB0 was negative, and in ophthalmological examination, vision was normal, fundus was normal, and sleep plate examination was the normal. In the urine routine microscopy, foamy urine with urinary protein 4 plus. HRCT chest, bilateral pleural effusion, which was right is more than left, then the multiple calcified lymph node in subcarinal and left hilar region. Sir, renal biopsy. Sir, renal biopsy of this patient shows the membranous nephropathy, sir. Sir, its detailed description will be sir provided later. Sir, next my provisional diagnosis, sir. Sir, a 13-year-old female child having chronic polyarthritis with joint deformity now presented with generalized swelling, nephrotic range proteinuria, and renal biopsy suggestive of membranous nephropathy. So, sir, provisional diagnosis is juvenile idiopathic arthritis polyarticular type RF negative with membranous nephropathy.
I think you should hold on here and
Yeah.
let's initiate discussion.
Yes, sir.
Dr. Neha ma'am, I think looking at the chat box and Sitaraman sir is also there. So can you go back to before investigations, that what were your differential diagnosis before investigations and what prompted you to do all these
Yes.
investigations? So I just request Neha ma'am to lead this.
Yeah, and actually, Anjali, any idea about
So,
the investigations in the earlier episode? Were kidney profile also screened at that time?
yes.
Yes, sir.
No?
Sorry, sir.
In the earlier episode, when she had received steroids,
Yes, sir.
do you think that there could have been a renal involvement still
Yes, sir.
that time?
Yes, sir. Yes, sir. Sir, the previous slide, sir. Sir, 1 second, sir. Sir, this is
So,
the
sir, we
investigation of August.
Yeah.
No,
This was
show the
the
investigation slide. Yes.
Yeah.
Yes.
See, when you look at the urinary protein is high,
Yes,
you
sir.
are this thing, would you be feeling that even the nephrotic was there at the time?
Yes, sir. Yes, sir. Sir, there was absolutely nephrotic during the sir previous phase also, but sir, this was not in the sir highlight. So, sir, during this time they was treating only as a JIS, sir.
Not investigated.
Yes,
Hmm.
sir.
Okay. Good. Neha, take over.
So what about
Okay.
ascites?
So,
Any
sir, I would
point of a
like that.
time did you feel like tapping the child for any other reason?
No.
Why ascites is there? And what was the?
So let
Did you
us
feel that it is because of GI or renal?
maybe
You were very sure that it is renal.
no. So can I intervene in between now? So we,
Sure,
let
sure.
us now first, basically we have kept this provisional diagnosis as JIA with membranous nephropathy. Now, membranous nephropathy is basically a pathological, histopathological entity. Basically, the child was responding to steroids. Child was steroid sensitive. We would not have biopsied the child, but the child having been an adolescent girl with multiple features like biopsy, and we were surprised.
Ma'am, your voice is breaking.
Later part, I would want the resident to present the DD as such first, and then we have a discussion from the rheumatology part, and then we can progress to the final discussion when we can combine both the rheumatology and the renal findings and have a discussion in the end. So if it's okay
Treated
with
earlier?
everybody, we can proceed with the DD first, and then
Where was
so what has happened is that when the child had
child
come to the
treated?
rheumatology department.
Okay.
Okay, so go ahead, Anjali.
Yes. Sir, the question was ki first it was sir as a renal presentation. Sir, it has the symptoms of the sir proteinuria and the sir decreased serum albumin previously also, but sir it was not treated or not sir managed previously. But sir this time it was suspected, sir. There are the multiple reasons: generalized swelling, sir. There is the frothy urine, urinary protein 3 plus. So sir, our first diagnosis was the nephrotic syndrome, sir. And sir, biopsy was done due to the sir. She is an adolescent female who is 13 years old with the sir joint involvement, sir. Sir, now sir, all our differential diagnosis is in line with the sir chronic polyarthritis and the sir membranous nephropathy, sir. So sir, there are the 5 diagnoses: polyarticular GIS, sir. Sir, systemic lupus erythematosus, sir. Pediatric onset adult type sarcoidosis, juvenile systemic sclerosis, and sir, Sjogren syndrome. Sir, first is the polyarticular RF negative GIA, sir. Sir, there is the multiple factors, sir, which is in the favor. Sir, C has a chronic polyarthritis. C has erosive arthritis with deformity. There is a no systemic feature like fever, rash, oral ulcer, fatigue. There is no lymphadenopathy, hepatosplenomegaly, serositis, acute phase reactant like ESR was increased. There is the absence of autoantibodies, ANA by IFA, and the immunoblot all are negative. There is a renal involvement, there is a specific point, renal involvement associated with the membranous nephropathy. Sir, there is the very uncommon, but is it reported? Generally, sir, in GIA, there is the association of the GIA with the amyloidosis, but not, sir, membranous nephropathy. But there are some cases where there is the association, sir. So there is the no other factor which is against the diagnosis. Sir, the next diagnosis, next our differential is, sir, systemic lupus erythematosus. The points in favor are chronic polyarthritis and the membranous nephropathy. What is against, sir? There is the erosive arthritis with deformity. There is no systemic feature like fever, fatigue, oral ulcer, malaria, etc. There is no lymphadenopathy, hepatosplenomegaly, or serositis. There is the absence of autoantibodies. ANA by IFA and the immunoblot all are negative. Sir, we have put the SLIC criteria for the SLE, but sir, there is the only 3 positive finding in the SLIC criteria, which were all clinical. There is a no immunological positive finding. So, sir, the SLE was not our first diagnosis, sir. Sir, next is the pediatric onset adult type sarcoidosis. Sir, the same feature, chronic polyarthritis and the membranous nephropathy was present, along with the hilar lymphadenopathy, which was, sir, present in the HRCT chest, and the absence of autoantibodies, ANA, and the immunoblots, sir. Sir, the features against this are no systemic feature, fever, malaise, weight loss, no cutaneous manifestation, no eye involvement, no peripheral lymphadenopathy, or normal calcium levels, sir. Sir, next differential is juvenile systemic sclerosis. Sir, in the favor is the chronic polyarthritis and the membranous nephropathy. What is against? There is no skin thickening, no Raynaud's phenomena, absence of autoantibodies like ANA by IFA, anti-topomerase, SCL70, and no lung or cardiac involvement like interstitial lung disease or pulmonary artery hypertension. Sir, next is Sjogren syndrome. There is the favor, chronic polyarthritis in the membranous nephropathy, but what is against? There is the no dryness of oral mucosa, no parotid enlargement, no ocular involvement, no Raynaud's phenomena, and the absence of autoantibodies like, sir, anti-Ro, anti-La, and the ANA by IFA. Sir, from here, sir, I want to, sir, give this session to Dr. Rinku ma'am, sir, for further discussion of the rheumatological disorder.
So good afternoon, everyone. Respected Chairperson, Dr. Sitaraman sir, dignitaries of Jaipur IAP on the dais. I'm thankful to Jaipur IAP and Dr. Neha for this opportunity to be a part of today's PG Clinic. I also appreciate the organizers for the supportive and innovative platform for our PG residents. So coming to our case, this is an adolescent girl who is presented with chronic inflammatory polyarthritis with
Are you
renal
logged on 2
involvement.
devices? Are you logged in for 2 devices? Your voice is echoing.
Echo is there in the voice.
Are you logged in 2 devices, 2 phones? Hello, ma'am? Rinku ma'am?
Yeah, now it's okay, sir?
Yes,
Yeah,
yes,
okay.
Yes, it's
Please go
better
ahead.
now.
Yeah.
Yes.
So now it's okay, sir?
Yes, please go ahead.
Yes.
Yeah.
Okay, now.
So coming to the case, sir, she's an adolescent girl who is having chronic inflammatory polyarthritis with renal involvement in the form of nephrotic range proteinuria due to membranous nephropathy. So if we see the clinical features of the girl, she's just having chronic polyarthritis. She does not have any systemic features, no fever, no oral ulcers, nothing. And the organ involvement is not there except for the renal part. And if we see the investigations, then the investigations are also suggestive of that all the nephrotic range investigations are there. The albumin is decreased, there's urinate protein is 3+, cholesterol is raised, acute phase reactant ESR is increased. So in a nutshell, when we see, it is a case of chronic polyarthritis with nephrotic range proteinuria. So in rheumatology, the most common condition which is associated with renal involvement, the first diagnosis that comes to our mind is definitely SLE. And this was the first diagnosis which was thought for this girl also. But as Anjali has also already mentioned, that the point against SLE were that she didn't have the clinical hallmarks of SLE. She did not have fever, no pancytopenia, no oral ulcers, alopecia, no any other organ involvement, and the immunological profile. The ANA was negative and the immunoblot was also negative. So the diagnosis of SLE was less likely in this case. So the first diagnosis that we thought came to be that is chronic arthritis. The most common cause of chronic arthritis in pediatrics is GIA. So GIA, polyarticular rheumatoid factor negative, associated with membranous nephropathy, was a final diagnosis. Now, a bit I want to speak about the association of GIA with renal involvement. So GIA normally is not associated with renal involvement, exception being systemic GIA, which is associated with secondary renal amyloidosis. So this is an interesting case because it is showing an uncommon presentation, but definitely it can be there. So GIA can have renal involvement, and so this was our first diagnosis in this case. I kept 3 other possibilities which were rare, but 3 other rheumatological conditions which can have this presentation. First I kept was late onset pediatric sarcoidosis, because the child was having chronic polyarthritis with membranous nephropathy, and she also, all the immunological profile, it was negative, and she had hilar lymphadenopathy, HRCT chest. But again, sarcoidosis, the negative points was there was no systemic features, no fever, weight loss, there were no cutaneous manifestations, no as such pulmonary findings, no eye or cutaneous involvement. I kept 2 rare possibilities also, like systemic sclerosis and Sjogren's. Both these conditions, they can have chronic polyarthritis, they can have membranous nephropathy, but the point against for that, the typical clinical features of both the diseases was not there, and the immunological profile, all the antibodies were negative. So from this presentation, I want to say a few takeaway messages for my residents. Number 1 is that in each and every case, we should perform a musculoskeletal examination also. So especially in those children which are having musculoskeletal complaints, and they should have a difference between what is joint pains and arthritis. So arthritis, what is arthritis? Arthritis is swelling of a joint, or 2 of 3 things. There is limitation of movement, there is tenderness of the joint, and there is wound. So this qualifies for arthritis. And what is chronic arthritis? Chronic arthritis is when the arthritis lasts for more than 6 weeks. And the most common cause of chronic arthritis, as I said, is GIA. So the definition of GIA is that is, onset should be less than 16 years, duration of illness should be more than 6 weeks, and we should exclude other forms of GIA. And GIA is a purely clinical diagnosis, and there's no diagnostic test which we need for making a diagnosis of GIA. The investigations that we do are for ruling out other DDs, and for categorizing the type of GIA, and for monitoring the progress. And rheumatoid factor positive does not mean that the child is having GIA. ANA positive does not mean that the child is having SLE. And from this case that we learn is, even it is uncommon that renal involvement is there in GIA, but we should always do renal monitoring in cases who present with GIA. Thank you.
Thank you, Rinku, for your wonderful inputs for the case. And I now hand over the mic to Vijeta so that she can explain us the biopsy findings, because that is how we will be proceeding with the diagnosis of the membranous nephropathy. And biopsy holds a very important part here because it helps us differentiate between the etiologies. Of course, we have some actually limitations that we have not been able to perform few tests which were financially overburdening for the patient. So over to Anjali, please continue to share your slides so that we can see the biopsy presentation by Vijeta.
Dr.
Good
Rinku, just Dr. Rinku, in sarcoidosis, is it that usually respiratory symptoms are also associated very much?
Yes, sir.
Respiratory symptoms, usually
Yes, sir. Yes, sir.
unresolved pneumonia, and usually we keep in the differential diagnosis. Na?
Yes,
So
sir.
this
Yes,
is
sir.
also a point against in this child.
Yeah.
Anjali, please share your slides again so that we can see Vijeta's slides. We can come back to the nephro discussion later once we see the biopsy findings. Yes.
A very good afternoon to everybody. Respected Sita Raman sir and all the dignitaries of the Jaipur IAP. And I would like to thank Dr. Neha Agarwal ma'am and all the organizing committee for giving me this opportunity today. So we had received one core of biopsy in our department, and the light microscopy showed just mild stiffening of the basement membrane and the rounding of capillary loops. There was focal mesangial hypercellularity in 4 glomeruli. Rest, the tubules, interstitium, and blood vessels were largely unremarkable, with just a few occasional casts here and there. Next.
Anjali, please keep on changing the slides. Please change the slide.
So
Yes.
this is the PAS stain, and this is a 40x view. And at this magnification, we can appreciate there is definite rounding of the capillary loops, and also there is definite thickening of the capillary basement membrane in the peripheral capillary loops. Ma'am, I think my pointer will not be working here, but I think everybody can appreciate that there is definite rounding of the capillary walls, and there is a thickening of capillary loops. And we now move on to the next stain, which is please move on to the next slide.
Anjali, move on to the next slide.
So next slide is of empty stain. That is also 40x view. Please change the slide, Dr. Anjali. Yeah, in this also we can see that there is definite rounding and thickening of the capillary loops. The thickening, although is not very global, it is focal and segmental, and there is definite rounding of the capillary loops, which are global. Please move on to the next slide. Now, this is a silver stain. Normally, in early stages, we do not see holes and crater, which are better appreciated when it is class 2 or class 3. In this, we can see rounding and definite thickening of capillary basement membrane. By looking at this morphology, we were expecting either this could be a minimal change, maybe a minimal change with a near normal morphology, because there wasn't any definite thickening which was global, and there weren't any other abnormalities in the tubules and interstitium. So then we moved on to the DIF study. Please change the slide. In the DIF study, 13 glomeruli were studied, and to our surprise, we had a immunoglobulin IgG 2 to 3 plus, which was fine capillary wall granular. It has very fine and confluent type of pseudolinear deposition. IgM was 1 plus capillary wall granular. IgA was 1 to 2 plus fine capillary wall granular. C3 and C1q were negative. Kappa was 2 plus and lambda was 1 plus. So based on these findings, we gave our diagnosis to be a membranous nephropathy. Looking at the autoimmune background, we also thought of whether this is secondary membranous or primary membranous, because to call it a secondary membranous, there has to be C1q positivity and a full house pattern, which was missing in this particular case. So please change the slide. This was the DIF study. In the IgG, we can see there is. Please move on to the previous slide. In the IgG, we can see there is capillary wall staining. There are deposits of intense deposits of IgG along the capillary walls. In IgA also there was, but though intensity was less, but few focal areas showed intense deposits along the capillary walls. There wasn't any mesangial granular or granularity in the mesangium. So it was just along the capillary wall, as we can see in membranous nephropathy. Please move on to the next slide. This is the IgM immunofluorescence, which showed only 1 plus staining. Next. Then kappa and lambda were also there. Kappa was 2+. This was also along the capillary basement membrane, and lambda was just 1+. It was also along the capillary basement membrane. Next. C3 and C1q were negative. So basically the entire panel was not a full house panel. It just showed IgG, IgA, and some amount of IgM and kappa lambda. C3 and C1q complements, they were absolutely negative. Next. So our overall findings were in favor of membranous nephropathy. Please move on to the next slide. When we see, this is a normal glomeruli. In the first image, you can see a normal glomerulus, and you can see that the capillary lumina, all of them are collapsible, and they do not have a particular rounded appearance. They are collapsible of any haphazard shapes. In this early membranous, we just see a bit of rounding, but there is no definite thickening, or maybe the thickening is just focal. It is not uniform or global. Then third image shows a very diffuse and a full-blown membranous case in which we find very thickened capillary basement membranes. Please move on to the next slide. So to differentiate between primary membranous and secondary membranous, on light microscopy in primary membranous, we see diffuse and global thickening of capillary basement membrane. There is no proliferation as such in the within the capillary tuft as we see in secondary. In secondary, we see sometimes capillary endocapillary hypercellularity, mesangial hypercellularity, and rarely even crescents may also be seen. There is usually no interstitial inflammation in primary membranous, whereas in secondary membranous, we frequently see a lot of inflammation in the interstitium. In the immunofluorescence study, in primary membranous, we have very fine granular or pseudolinear immunoglobulins deposited along the capillary walls. C3 is frequently deposited. Whereas in secondary membranous, we have a full house pattern. As I've already mentioned, all the immunoglobulins are deposited, including IgG, IgM, IgA, kappa lambda, C3, and C1q. Presence of C1q is very important in secondary membranous. Without positivity of C1q, we cannot label any membranous as secondary membranous. Location of deposits is also very important. In primary, we just see along the capillary walls, whereas in secondary membranous, we mostly we find some deposits along mesangium also, in the mesangium also, and even in extraglomerular location, we find deposits like TBM, tubular basement membrane, and blood vessels also. C3 and C1q are frequently deposited in blood vessels in secondary membranous. Electron microscopy is very important and very useful. In primary membranous, we just find subepithelial deposits. Absolute subepithelial deposits are seen in primary membranous, whereas in secondary membranous, along with subepithelial electron dense deposits, we see some EDDs in mesangium and subendothelial location also. And if if a membranous is secondary to lupus nephritis, then we find tubulo-reticular inclusions also in the endothelial cells. Next. So this is the electron microscopic image. In primary, as you can see in the center, this black cylindrical thing is a RBC. This is a capillary lumina, and this is the entire is the capillary basement membrane. The star depicts the EDDs or the electron dense deposits, which are located in the subepithelial location. The arrows, they depict the arrows are just over the podocytes. You can see some podocytes, and you can also appreciate podocyte food processes over there. And just beneath the podocytes, we can see these electron dense deposits. In the second image, in secondary membranous, we can see along with these subepithelial deposits, some amount of mesangial deposits are always present in majority of the cases. Next. So this is a case of membranous lupus nephritis electron microscopic picture. In this, the blue arrows, they are depicting a tubulo-reticular inclusion inside an endothelial cell. So if we find this tubulo-reticular inclusion, then it kind of confirms a case of lupus nephritis, because these are mainly seen in lupus nephritis. Next. So basically, the possible mechanism in membranous nephropathy, in primary membranous, the antigens which are the native podocyte antigens, they act as antigens, and the antibodies, circulating antibodies, they come and they form complexes at that particular sites. Therefore, we get absolute subepithelial deposits in primary membranous. Whereas in secondary membranous, especially in lupus and all, we have circulating antibodies. So some of the antibodies, they get deposited in the subepithelial site, some get deposited in mesengium, and some get deposited in subendothelial location. Next. So how to proceed with a case of membranous nephropathy? First of all, we apply PLA2R. If it is a case of PLA2R positive, 70 to 80% cases of primary membranous nephropathy are PLA2R positive. So either they are, if they are PLA2R positive, then we label them as PLA2R positive primary membranous nephropathy. Otherwise, we have to look for, if there is autoimmune background, then the EXT1 or extron 1 or 2, maybe it may be associated with extron 1 and 2, NCAM, TGF, BR3. If IgG pattern is global, then THSD7A, PCDHS is positive. And if it is segmental, then we think about NEL1. NEL1 is another upcoming antigen which is common in Asiatic population nowadays, though it is not very common in the USA. But since in Asiatic population, a lot of indigenous medication is used, and these herbal and Ayurvedic with heavy metals, and also there is upcoming this trend of using skin whitening creams in Indian. So this NEL1 associated nephritis is membranous nephropathy is increasing in children. If it is not PLA2R positive, then SEMA3B is another which is quite common in pediatric population. Other type of membranous nephropathy are seen in adults with monoclonal or polyclonal immunoglobulins. So we'll not be discussing them here. Please move on to the next slide. So coming back to our case, we had a very diverse clinical and histopathological findings. So there was an autoimmune background, there was history of rheumatological involvement and joint pain since, I think the patient was 2.5 or 3 years when the mother gave history that she was just 2.5, 3 years old when she started complaining of pain and other symptoms. Then she was on and off indigenous treatment with some local practitioners who gave medicines in small packets, which there is no details what she was taking at that time. And then there is focal mesangial hypercellularity on light microscopy. On IF also, along with IgG, there was some amount of IgA. So, but then there was no C3 and C1q. So we could not label it as primary or secondary because there was discrepancy, somewhat discrepancy between few things. And since we do not have PLA2R, electron microscopy, or even IgG subclass, so we could not differentiate between primary and secondary membranous. If IgG subclass would have been there, then in primary membranous, IgG4 is predominant, and in membranous nephropathy secondary to lupus, IgG3 is predominant. So what further can be done? So in this case, if it is a PLA2R positive, then it is primary membranous. If it is not, then it can be positive for SEMA3B since the patient is a child. Then NEL1, because patient has history of indigenous medication. And extron 1, 2, because there is autoimmune background, and extron 1, 2 is most commonly seen in SLE, membranous nephropathy secondary to lupus nephritis. Then electron microscopy would be very useful here, because in primary, as I've already mentioned, in primary membranous nephropathy, we will just get subepithelial deposits, whereas in secondary, we'll get some mesangial and some subendothelial deposits also. So I think this case further needs to be done, and maybe if we can plan further investigation, so we can come to a conclusion for the renal aspect, whether it is primary or secondary membranous. Thank you.
Thank you, Dr. Vijayita, for the important insights into the histopathology of the patient. And Anjali, I would request you to kindly come back to the point where we had left in the renal discussion.
Yes, ma'am.
So now we have already seen that the patient, yes. Can you come back to the slide where we had left after we had discussed the part?
Yes, ma'am. Yes, ma'am. Ma'am, after rheumatology part, there is the part where we strongly suspected that this is the SLE.
Yes. So basically,
Yes, ma'am.
while working this case, we had few dilemmas. Real child when presented to the rheumatology, just leave it here and I'll just go further with this. So what has happened is that when the child come to the adult rheumatology department, so the first learning point here was that we should have there and then investigated what the child was suffering from, because having had one autoimmune disease already into the system, the child most probably was having either a manifestation of the same or some kind of overlap, or SLE, as the child was an adolescent girl with proteinuria, with the systemic symptoms like joint pains and arthralgia. So this was very important that we could have made a diagnosis there and then. But having said that, we generally tend to miss some of the findings in a routine OPD practice. So now, then the child to a little skeptical about the fact that although the child was steroid sensitive, symptoms again that or a form comes later age or at a early age.
Neha, your voice is getting cut here.
It's not like that, but the guidelines definitely tell us that if you have any unusual presentation, any atypical presentation, see
Neha ma'am? Neha
sir.
ma'am?
मैडम
Your
वॉइस
voice is
कट हो गई
breaking.
आपकी नेहा, डॉक्टर नेहा वॉइस टूट रही है थोड़ी
The
सी
voice
ना,
is breaking.
नेटवर्क प्रॉब्लम आई थिंक.
मैम फोन से कनेक्ट कर लो. Are you there? Anjali, you can continue till then.
Yes, sir.
Yeah.
Yes.
So what was she talking about? You can.
Yes, sir. Sir, actually, ma'am was talking about the SLE, sir. Sir, in this case, sir, there is the strong suspicion of the SLE, sir, on the basis of the, sir, female child, adolescent girl, sir, joint pains, proteinuria, sir. Sir, but we couldn't conclude the SLE due to the, sir, negative, sir, investigation marker, immunological markers. But sir, there is the thing, sir, one point, sir, which we want to highlight in these slides. Sir, in the membranous lupus nephritis class 5, sir. Sir, it is the form of lupus nephritis may be indistinguishable from idiopathic membranous nephritis clinically even serologically. The lesion accounts for 20% of patients with lupus nephritis and often present as nephrotic syndrome in young women who do not have other clinical or serological manifestation of systemic lupus, although they usually develop these latter. And in patients with lupus membranous nephritis, anti-DNA antibody levels and the ANA levels are often low, and the antibodies is of very low avidity compared with the patient with a class 4 lesion. So, sir, we want to say this, sir, even though there is the no immunological marker is present now, but sir, this patient could also be SLE in the sir later in the future, because sir, this class of the membranous lupus nephritis can be present sir later in the sir time. So, sir, we have to sir put this patient in our radar for sir future SLE prospects, sir. Sir, our next slide is sir about the discussion. Sir, there is a sir most important point that diagnosis can be challenging due to the variable and the mixed presentation and changes in the symptoms over time. Sir, if we do the early diagnosis, it is associated with the improved outcome. And sir, second thing is sir, an interprofessional team approach is crucial for improving clinical outcome and the patient quality of the life. Then the definitive diagnosis often requires close follow-up and identification of the characteristic clinical laboratory and the radiological findings and the CL monitoring of the various parameters, sir.
Okay, right. So it was a nice presentation. There's one question that what is the clinical difference between the primary and the secondary membranous nephropathy?
Okay, sir. Sir, actually, membranous nephropathy, it is a sir biopsy finding, sir. So, sir, there is the mainly, sir,
So
what
there
we
is no
found.
clinical difference. No? Clinical difference would be just the same.
Yes,
Proteinuria, edema.
yes, sir. Yes, sir.
Is there any? I don't suppose there's any clinical difference.
No,
So
sir.
that's how you differentiate it from SLE. Any comments from Sitaman, sir?
Yeah,
Yeah, hi.
I think
Am I audible?
it's a
Yes, yes,
wonderful
ma'am.
presentation. Must compliment all the presenters. And really, Dr. Vijita's execution of the pathological findings is extremely good, because we always find that pathologists have the last laugh. Clinicians keep on struggling with the diagnosis. And but I have one question regarding that. This kind of association has been noted earlier, and if at all, were could we have picked up if we had done a biopsy in the earlier first episode and noted whether the child had nephropathy, and the evolution, as Dr. Vijita showed us, a mild and moderate manifestations of nephropathy. Is it possible that we could have picked up that nephropathy if we had done a biopsy in the first instance?
Yes. So may I
Yeah.
answer this, sir?
Yeah, Neha.
So actually the message here is very clear that we should have biopsied this child at the first instance. And this very often happens that we in the dominating rheumatological complaints, we tend to oversee these mild proteinurias, the mild fall in GFR. So these things are very important and they should be taken care of there and then, because we do not know what kind of challenge we are facing renal point of view से हम क्या देखना चाह रहे हैं. So having said that, the child, if it would have been a SLE or membranous nephropathy, or anything for that matter, we even thought of amyloidosis at some point of time. When the child was, because it was a chronic disease and rheumatoid is known to have association with these kind of pictures in the histopathology. So always biopsy is a window to a lot of things. So it's even if the child was responding to steroid or not responding, the biopsy was very important at that point of time. So we already lost a kind of, window of 1 year in this patient. But having said that, the child presently is doing a little not so badly. She's doing well. The GFR is good, but she is proteinuric and she has been having these flares with the rheumatological complaints off and on. So this has been her third episode with us now. If Anjali has not discussed the course of the patient presently, so she recently got admitted again with the same flare and with significant proteinuria, nephrotic range proteinuria. And then we took the decision of challenging her with not only steroids and tapering them from there and there, so on, but also adding on a CNI agent calcineurin inhibitor because we were worried about the, constant proteinuria which this child was having. And the another problem is that serial monitoring of these patients is very important because we never know when we might have a sudden, manifestation of a delayed SLE kind of picture also in these patients. Because sometimes these things are subdued by a lot of immunosuppression, which we have already given in these patients. So things get, suppressed and they might manifest later. And even literature says that there is a tendency to delayed SLE or these patients may be immunologically positive in some time later in their course of disease. So I would still be, monitoring this patient from an immunological point of view and would be doing her ANA and dsDNA and regular intervals, like, yearly or something of that sort.
But do you think that the protocol would have changed if it was picked up, nephropathy was picked up in the first instance?
So, sir, another issue was that we had few limitations. I mean, like picking up membranous is not enough. We need to classify membranous into primary and secondary because suppose the membranous is because of not this autoimmune disease, but because of some other agent. For example, in this case itself, the patient has a very, doubtful history of query indigenous medicine and NSAIDs. So having said that, they might be the inciting factor behind the disease. But literature says that when you withdraw the inciting agent, the patient recovers.
Yeah. See,
But
actually,
this patient is not showing that. So we actually clinically ruled out a lot of things, but we could not really point to a lot of things because we did not have access to PLA2R and IgG4 sub antibody, and other antigens for that matter. For example, as Dr. Vijeta said, we should have done exon 1 and 2 as it was an autoimmune disease. But we could not do because, I mean, financially, it's very overbearing for the patient.
So, Dr. Vijeta, would that have picked up whether it has been a secondary consequence of any indigenous medicine or it was a part of immunological mechanism?
Sir, definitely, sir. Sir, when it is associated with indigenous medication, NEL1 is commonly associated with indigenous medication usage. So all these patients are usually NEL1 positive in such cases who have history of these NSAIDs, these indigenous medication use.
Okay.
And if we talk about autoimmune disorder, then EXT1 and 2, they are commonly associated with lupus nephritis. But I think, sir, electron microscopy would be more useful because in this case, there is a multiple factors are there. So it is not possible to go for so many things. If it is showing deposits in mesangium and in subendothelial location, then it is a secondary membranous nephropathy. So definitely then it will have an autoimmune background. And if it is showing absolutely subepithelial deposits, then it is a primary membranous nephropathy.
Okay. Great.
So what was the final treatment the patient was on?
Yes, so basically now we have put the child on tapering doses of steroid with overlapping her with CNI. So we can use any agent, either cyclosporin or tacrolimus, for a shorter period of time, not for the whole 2 years. But having said that, PLA2R plays a very important role here because according to the titers of the antibody, which are of course costly, we generally classify the disease as low, moderate, or high risk. And we constantly monitor the UPUC and the proteinuria and the renal function of the patient. If at any point of time the child is showing higher titers, like that is more than 50, and the child shows worsening of UPUC ratios and her EGFR, we straight away go to higher immunosuppression, like higher doses of MPS and alternating doses of cyclophosphamide. That is called as the Ponticelli regime. But since our child was not doing so badly, but still was proteinuric, looking at her, the number of flares which she has already had, we have presently put her on cyclosporin presently, and with our plan is to bring her to make her non-proteinuric, and then we plan to actually kind of give a bridge therapy which would help the rheumatology manifestations also, and ours also in the form of rituximab. So rituximab is again a reserve drug which is generally given to either a moderate risk patient who is not doing well or a higher risk patient. But higher agents like alkylating agents like cyclophosphamide are reserved for very high risk patients, which this patient is not, surprisingly.
Well, as a clinician, I would like to know, looking at the age and financial background, what would be the prognosis of this child with all these intervention, and what would be the quality of life? Dr. Nair.
Sir, from renal point of view, I am not so actually disheartened because I am surprisingly the child is doing okayish and doing well. But of course, talking about multidisciplinary management, which is the actually the taste of the town now, because we cannot just go about treating what we treat well, but we have to collaborate with other colleagues. Because finally, when we are talking about a good quality of life, I would vision this child as going to a college, doing well, reading, writing, and looking at the present scenario when she's already having deformities and
Yeah.
limitation of movements in the right limb,
Yes. Yes.
would want to offer her some kind of palliation, and physiotherapy for a start. And of course, controlling her renal manifestations, which we are trying to do with her immunosuppression. But at the same time, I want to stress upon the fact that we should always think about not just managing, but we should keep constantly monitor our patients for side effects. Because see, every drug will come with its own, box of and Pandora's box, because it will come with its own side effects. For example, if I'm giving her cyclosporin, at the same time, I need to consider that she might turn into, she might have hypertension, she might have gum hyperplasia. Cosmetologically, it's not good for her because she might have, a lot of hirsutism. So we might shift to another therapy at some point of time. But having said that, it would require a constant monitoring, and that is what we have to do in these patients. But renal point of view, I'm very happy with how she's doing right now. But Rinku can better answer about her rheumatological issues, which she might face later on in life.
Particularly related to bony deformity, already she
Yes,
is
yes.
having.
Because she already
Yeah,
has a
Rinku can comment on what she
yes.
feels like when she's when the treatment is going in tandem with the nephrology, and they feel fairly confident with the like of clinical management. What do you propose? How do you how will you counsel the parents regarding the long-term management or long-term prognosis?
So
Yeah.
regarding treatment, the treatment that they are giving for membranous nephropathy, immunosuppression with steroids, this will cover the rheumatological manifestations also. The deformities that she has already developed, we can't do much for that except for physiotherapy. And if it is too much deformity, then orthopedic correction is needed. But for future flare-ups of the disease, we can control with immunosuppression. And the treatment that we are giving at present from the nephro side, it will cover most probably the rheumatological manifestations also. But if they are not controlled, then we need to escalate the immunosuppression. We can either switch to cyclophosphamide or we can then upgrade to rituximab. And if she's having peripheral joint disease more, then we can add methotrexate also.
Many of these rheumatology features do occasionally have flare-ups. So do you think the flare-up would be, going along with the nephropathy also, or you think that has to be managed on its own?
Actually, so that is the interesting part in this case. Actually, we were not able to make a rheumatological diagnosis in this case.
Okay.
So membranous nephropathy is associated with some rheumatological conditions. So most common is SLE. But she was not fitting in SLE because she didn't have any clinical markers and immunological markers for SLE. And GIA. GIA is not so commonly associated with renal features. So that what made it uncommon and interesting. So what you're saying, sir, that and the interesting part is that whenever she had joint pains, she had proteinuria. So that was the autoimmune association of both the diseases. That sort the picture that this is also autoimmune and this is autoimmune. So whenever she has flares, she is also having proteinuria. And once you control the proteinuria, the joint features also improve. So if we are giving immunosuppression for the kidney manifestations, they will also cover the rheumatology part. We don't need to separately give any other immunosuppression for the joint complaints. We can give naproxen something. But as I said, if it is not, the joint problems are not going with the immunosuppression which are giving from the nephro side, then we can either escalate it to rituximab or cyclophosphamide.
Great. Very nice
Well, very
presentation.
well put.
So we have answered most of the questions in the chat box.
Yeah, basically it is the how much sticks to the goes up, na, that also. So effective counseling is very good, as Dr. Sita said. Effective counseling is very important. Otherwise, many of them, the parents are tired and then they just leave the treatment in between. Na, that is, and every drugs are free of cost, Dr. Rinku here in JK Lawn. Every drug,
Yes,
Dr.
sir.
Neha.
Yes, sir. So we are giving free of cost cyclosporin, and I mean all the actually treatment is free here.
Yeah, rituximab is also coming in.
Yes, yes. The most of the immunosuppression is free here, sir.
But still, the counseling is very important. Counseling, and then the
Yes, sir.
properly follow up the child is very important for the
So
parents.
one of the
And
major problems with this patient has been very irregular monitoring, which is a very difficult task because unless you keep them under, your umbrella, they would really linger on to opting out for indigenous medicines, and that would lead to worsening of the primary disease.
So Anjali can, I think,
but
just
wonderful
in a
presentation
nutshell.
and wonderful discussion.
Yes, yes.
Really, we have seen so much of the discussion, so in details. Everyone was very
So,
clearly discussed
learning
here.
points from Anjali in nutshell, quick.
Yes, Anjali, can you just share the take-home messages once again?
Anjali should join as panelist.
No,
I
I think
believe
she
she
is
is not
asking
there.
for making her the panelist.
She is left.
No, actually, I think she's again asking for adding her to as the panelist. There's a message in the chat box.
I'll just check.
Dr. Mohit,
They're making. They're
yes,
making.
we
Yeah.
have the Tuesday PG clinic also
Yes, sir. So
from
it
the
is
central
just a beginning. We are
Yeah.
just
So
putting the
can
flowers on
we
the
have
bus.
some case discussion like this in that one? Na? Very
Why not?
useful.
Definitely,
So
definitely.
whenever it is convenient, Tuesday evening, 6 to 8, every Tuesday evening. So whenever it is convenient, you can just talk to me and then we'll fix one day and then we'll be
Done, sir.
together.
Done, sir. Done, sir. We can definitely. Yes, Dr. Anjali's come back.
Yes, sir.
Yeah,
Yes,
yeah.
sir.
Yeah,
You
so
can
can you
wind
just
up now.
summarize
Yeah.
Yes.
learning points from this case for everybody.
Yes, sir. Okay, sir.
बेटा नीचे जाके उसको वो करो आप
Slide show.
करो स्लाइड शो पे लाओ
सर एक सेकंड
ऊपर से भी हो जाएगा नीचे से भी हो जाएगा
सर ऊपर से तो नहीं हो रहा सर
नीचे से करो यहाँ पे होगा देखो उसको बड़ा
जो
कर
आइकन बना हुआ है ना,
कहाँ पे मैम
इधर
नीचे
ही
होता है icon,
यहाँ
ये नीचे वाली बार में. Yes,
नीचे
here.
ये रहा
yes ma'am yes ma'am ma'am there is a take home message for this case so my so first thing is not all steroid sensitive nephrotic syndrome should be treated as a simple nephrotic syndrome there is an association manifestation other systemic or rheumatological illnesses second thing is the all nephrotic syndrome need not biopsy but as in this case the patient is a 30-year-old adolescent female with joint pains so we do not be so we do need biopsy even if she is steroid sensitive for the ruling out of the SLE and the other rheumatological disorders. Third point is, ma'am, if we want to diagnose someone as a SLE, so anti-nuclear antibody tests will always be confirmed by the IFA. Next thing is, in adolescent girl with joint pain and proteinuria, always rule out SLE. Ma'am, as this case, which was presented 1 year back with the proteinuria and the proteinuria, ma'am, but we have not do other investigation regarding the ma'am kidney or renal involvement. So there is the importance of the renal monitoring. Proteinuria and hematuria are the early signs of renal involvement in juvenile idiopathic arthritis and should be monitored in the patient and the detailed screening of renal function is necessary to monitor patient with JIA for any signs of the kidney disease.
so Good, good. Thank you. Dr. Neha, can you just tell what are the indications of a biopsy in a newly diagnosed case of a nephrotic syndrome?
So, as was previously understood that we should biopsy if a child is less than 1 year and more than 10 years, it is no longer, warranted now. The newer guidelines say that only if a child is not, either the child is behaving in a steroid resistant manner, for that matter, if an initial nephrotic syndrome, having been given 6 weeks of daily steroid therapy with 2 milligram per kg. So previously we used to say that after 4 weeks we used to biopsy these children. But nowadays we give them a margin of 2 weeks, that is the confirmation period. And even if after that the child does not show, non-nephrotic range proteinuria, the child needs to be biopsy. Another thing is that a child who is actually showing atypical features, as in this case, like systemic features. So these children should be biopsy. And of course, when you have a child who is having a low C3, low complement for that matter at the presentation. So hematuria, proteinuria in the nephrotic range and a low C3, we should always think, if we have ruled out PIGN, that we should always think of if hypocomplementemia is persisting, we should consider biopsy in those children, because there is a term called as C3 glomerulopathy, or as we used to call it as MPGN type 2, but I mean that would require a lot of discussion. Just a blanket term I'm just using, but these patients should also be biopsied as such.
So there's
And
no
of
age
course, when you
criteria
are
as such now.
anyways, you are suspecting renal biopsy is indicated in lots of other features also. But having said, in context of nephrotic syndrome, that's what I'm trying to tell
Yeah,
you
yeah.
right now.
No, no, in case of nephrotic syndrome, if you have diagnosed a child who's less than a year, say in infancy, then
So
is
in
biopsy
complementary nephrotic,
compulsory in this
we
case? That's what
generally
I'm saying.
don't do, no, no, we generally don't do biopsy nowadays,
You don't do
because
biopsy.
yeah,
You have
that
given
would
you
not
have
really
given him a
change the.
6 weeks case, say initially
Yeah, for
4 to 6
example,
weeks of
if you
daily
have a congenital
steroid. You have given
nephrotic.
him initially a daily steroid for say 4 to 6 weeks. Then the urine protein is negative, and then suddenly again after 15 days it start comes positive for the
That is
3 days.
actually the first relapse.
Yeah.
You need to
So
treat the relapse, not biopsy the child.
so that okay, that's what
Yeah.
I'm saying.
But
So now
then there
what
is a
happens in
term.
some cases we have seen when you're treating
Yeah.
the relapse,
So actually, Dr.
the
Mohit, there is a
patient is
term called as late steroid
yeah, I
resistance.
got it. I got the
Yeah.
point. But
So then
sometimes
you need to
people
biopsy the child.
sometimes the patients are on a low dose steroid. I have seen many a times. They have
Yes.
kept on 5 milligram every day or an alternate day. When you ask them since how long it is, they say it's going on for 3 months. So what is this regime? Because I am not aware of this kind of a
Yes.
regime
So
to keep the
nowadays
patient.
we use this regime called as long-term tape alternate day therapy in patients, and I think that would need another discussion on the newer guidelines of nephrotic steroid sensitive nephrotic syndrome, and
That's a
we
very
can have another
important
discussion on
question
the
because
IAP
we
platform for
often
that.
see such patients in OPD.
Is
Most of the
it that,
clinicians.
Neha, what Dr. Mohit is saying, these children ultimately they become the steroid dependent, like, no?
That's what I'm
Yeah,
saying.
so because of dependence only, we are giving them low dose steroids.
Low
So
dose steroid.
nowadays, the guidelines say that we should go towards steroid sparing rather than giving high dose and bombarding the patient with high dose steroids. So some patients do very well on very low dose steroids, especially those who are
But
frequently
then how
relapsing.
long? But how long?
So that depends upon the patient, but generally LTAD is continued for a period of, I mean, like, variable period of 4 to 8 months. We can, it depends upon the patient, how the patient is doing. In spite of
And
the
then you
LTAD therapy,
suddenly stop or you taper because he's already on the low dose. He's on 2.5 milligram. Because I've
so then
seen
you
patients,
stop. Then there is nothing lower than that actually.
yeah. So then you stop it after
Yes.
4 8 months.
But see, we need to see the clinical course of the patient actually. If the
Okay.
patient has been relapse free for a period of like 1 year or 6 months, why would I just continue giving steroids to that patient?
So do
And
you
of course, we
right,
need to monitor for side effects.
right. And do you advise some follow-ups besides the urine protein in such nephrotic syndrome patients? What
So
routine
generally,
investigations they should
yeah.
go into besides for protein?
So generally for a steroid, I mean, like a child who's taking chronically steroids,
Right.
we generally tell them to get a 6 monthly checkup of their eye examination for IOP and cataract. Number
That's for
one, then they
steroid
of course
regarding kidneys.
yes, and then they should always be, monitored for side effects like cataract ke alawa. They should have a BMI monitoring, blood sugar monitoring, especially in children who have a family history of diabetes. HbA1c should be monitored. So all these things need to be monitored in these
When is
patients.
DMSA, DTPA, urine protein creat
No,
ratio,
no.
other such
That's
renal tests
totally
are
out of,
required for such children?
that's totally out of context, Mohitji.
Okay. So that's the
ज़्यादा ज्ञान
question.
आज नहीं ले सकते आप.
Okay.
Acha, one more clinical
Neha?
question, particularly in relation to this case. When a child is on immunosuppressive drugs and steroids, and can he join school and regular activity?
Definitely,
He or
sir. Why
she?
not? But sir,
Okay.
it is
Any
just important
precautions?
that they have to take some precautions, not on low dose steroids, but when you have given a child rituximab or higher immunosuppression like cyclophosphamide or MMF,
Cyclophosphamide.
they have to take precautions, sir.
So how do their vaccination schedule alter in such cases
So,
where the
Mohitji,
patients
I
are on
would say that
steroids?
we need another lecture on vaccination in nephrotic syndrome and
Special lecture.
immunocompromised.
And Neha, what is the youngest age at which we have seen the nephrotic syndrome, youngest
Also,
child,
recently we had this actually 2-month-old child.
2 months old?
Yes, sir.
So what you started in that child? What
So,
treatment?
generally, these patients are actually genetic nephrotics. They are like NPHS2 or these kind of.
Like congenital nephrotic syndrome, which was
Yes, sir. So
initially
this is
described like that.
congenital nephrotic, less than 3 months. Generally, they don't really fare very well, sir, because they have hypoproteinemia, multiple issues. They have hypercholesterolemia to the tune of like 100,000. And these patients have chronic multiple issues with sepsis. And so they don't really fare very well. And in congenital nephrotics, the therapy is not steroids, but we generally give AC inhibitors, thyroxine, aspirin to prevent, thrombotic complications. And accordingly, and supplementation of albumin chronically, nutritional part has to be taken care of. So all these things are there, sir.
So, ma'am, can you
And
help us quickly
these children
revising our
usually do
steroid
not do
sensitive
well.
and steroid resistant
Prognosis is
nephrotic syndrome?
guarded in them, na?
Pardon,
Prognosis.
Dr. Murali?
Overall prognosis in these children at 2 months
Sir,
of age who is
congenital
developing
nephrotic का बहुत poor prognosis होता है, sir.
poor
नहीं,
prognosis.
मैं आपसे बोल रहा हूँ, can we
But
quickly
having said
revise?
that, these are genetically positive. I mean, like they have mutations. So these NPHS2, they, I mean, like survive कर जाए तो बहुत अच्छी बात है. I mean, like in countries like England and US, they are doing chronic PD for these congenital nephrotics, making them feasible for transplant in later age. But that kind of, I mean, that's a dream for us at present actually.
And I'm saying, can we have a quick revision of the latest steroid sensitive, steroid resistant, and refractory nephrotic syndrome
So
definitions?
Mohit, I think we should not do it on this platform because I mean we can do it at we can have another lecture on steroid sensitive nephrotic syndrome. All the guidelines, they have been revised by ISPN recently, and I mean that would be better actually because I mean
Done.
other gyan is like a poison actually.
Okay, done.
ओए
Thank you so much.
तो
Thank you so much.
सारा
IAP
आज
Jaipur,
नेफ्रो
thank you.
पूरा ही
NGK
कंप्लीट मत
non.
कराओ आज ही भाई.
हाँ, आज ही कराएंगे सर.
हाँ, ठीक है.
Thank you.
But
Dr.
I must
Sitaraman, sir.
congratulate the whole team of IAP and also Department of Pediatrics, Nephrology and Rheumatology. And especially congratulations for Dr. Anjali. She has presented very well.
Very
Yes, sir.
well.
He has put in a
Yeah.
lot of effort for this case. I must
Excellent,
thank her.
Yeah.
And of course,
Excellent.
this platform is very important for all the PGs, and I stimulate them to come and present, and that would really help them in a long way.
Okay.
Very
Very
We've
good.
already, for the next time, we have already 2, 3, 4 people pitching in that we will present the
Yes.
case, and
So
that's
Dr.
good.
Khatri sir has already,
Dr. Khatri sir, Dr.
volunteered.
Ankit Mangla,
Yes.
and Fortis people have come forward. I have received the messages from them to present. So that's, I think, a good point.
Thank you,
Okay then.
everyone.
Thank you.
Thank
Okay.
you. Thank you
Thank
so
you.
much.
Thank you very much, Jaipur
Okay.
IAP, for
All
giving me
those who have
opportunity
not
to attend
registered
this
for
wonderful
pediatric infectious
case
disease
presentation.
conference on 5th and 6th July, please do earliest.
Yes,
Early
that's the
bird,
key
early
message
bird
here.
is till 8th of June. Right? Thank you.
Okay.
Thank
Thank you.
you.
Congratulations,
Thank you all.
Anjali,
Thank you.
also, and the guides also,
Bye-bye.
Dr.
Thank you, Rinku, Dr.
Mehta, Dr.
Vijayta,
Rinku,
everyone who has,
Dr. Vijayta,
put efforts.
Atul Shankar sir, Mohit Bora sir, and Dr. Sitaraman sir. Thank you so much.
Thank you, sir, for your presence
Thank you.
throughout the lecture. Thank you so much.
Thank
Thank you,
you.
everyone. Bye-bye.
Mohit,
Thank
can we
you.
have a
Bye.
quick
Thank you, sir.
picture?
Bye.
Mohit,
Yes, ma'am.
can we have a picture before logging out? I mean, everybody can just put on their cameras and we can have the panel mode.
I think most of the people have logged out already.
No, but the panelists I'm
No.
just talking about.
Yeah, panelists can
Yes,
do it,
yes.
definitely.
Yeah. I mean, that for the records.
Yeah. I have clicked in between. I'm good
Okay,
at
that's
it.
great.
Yeah.
Okay. I will also share. I have also clicked one.
That's okay then. Fine, sir.
Yeah, even I have clicked. I'll share.
Okay. Thank you, everyone. Thank you,
Okay.
everybody.
Okay.
Bye.
Thank you. Thank you, everyone. Bye. Bye.
Thank
Right,
you.
sir.